بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. My name is Dr. Islam. I'm ER consultant. Today, our topic is acute onset diplopia and the ER management of this complaint. First of all, we'll have some definitions, the overview. This diagram is showing the extraocular muscle distribution around the globe. We have four similar muscles, two similar in each opposite side. One superior rectus, inferior rectus, lateral rectus, and medial rectus. This is the right eye for sure. And two oblique muscles, inferior oblique and superior oblique. This is the anatomy of the extraocular muscles, as you can see. And this is mentioned here, the innervation of every muscle. All muscles are innervated by cranial nerve number 3, the oculomotor, but the superior oblique is innervated by trochlear nerve number 4, cranial nerve number 4, and the lateral rectus is innervated by the abducens nerve or the cranial nerve number 6. Okay, double vision or diplopia is the condition in which you will see two or more images of the same object. It is pathological for sure. It is not normal to see two or more images for the same object. The differentiation of the diplopia or the categorization of the diplopia, it can be monocular or binocular, vertical or horizontal, and acute or gradual in onset. Most cases we are seeing in ER are binocular diplopia, with the most common cause of binocular diplopia is the cranial nerve palsy. The etiology of the diplopia can be from the eye itself, pathology in the eye, pathology in the brain, or systemic pathology, as we will see later. So diplopia can be horizontal, like this, two adjacent images of the same object, horizontal side by side. Can be vertical, two images over each other. It is up and down. It is called vertical diplopia, and there is diagonal or oblique or torsional diplopia, which has the two images are oblique in arrangement. The monocular diplopia is usually related to eye pathology inside the globe itself, not the orbit, inside the globe. So it can be problem in the lens, problem in the retina, or refractive error. And it can be also starting from some dryness in the eye, some corneal irregularity, or sometimes some cataract. We have clinical tip here. It is the pinhole test. The monocular diplopia is usually abolished or improved with the test of pinhole vision. If you apply a pinhole in front of the patient, the eye of the patient, and order him to see through the pinhole, the monocular diplopia will be improved. He will see one vision, not double vision, except in one situation, if the monocular diplopia is related to a cortical lesion. Otherwise, all monocular diplopia will improve with pinhole test. The binocular diplopia is not related to the refractive error or to the light beam going inside the globe. It is usually related to something outside the globe, not in the anterior chamber and posterior chamber, not in the lens or retina or conjunctiva or cornea. It is related to something outside the globe. Can be related to the extraocular muscle, can be related to the innervation of the extraocular muscle, can be related to the orbit abnormality, can be related to the brainstem abnormality, can be related to the cerebral abnormality or can be related to systemic disease. The difference between monocular diplopia and binocular diplopia. In monocular diplopia, if you close one eye, the diplopia will persist. So you have double vision if you are seeing by your both eyes. If you close one eye, the diplopia will persist in monocular diplopia. In binocular diplopia, the diplopia will improve or will be absent if you close one eye. As the problem in the binocular diplopia is the convergence or the imaging of the object with while seeing by both eyes. It is not related to the structure of one globe. So as we see in the diagram here, this is the normal vision. The distance are same, and there is convergence with both eyes working together to see one image. But here, this right eye is deviated a little bit to the medial side. So the distance is different now between the right eye and the object and the left eye and the object. So the image started to be double vision. So the problem is not inside the globe, it is outside the globe. So if you close one eye, the diplopia will be improved and the vision will be improved also. Okay, binocular diplopia can be related to any of the etiology we said a while ago, and it is the commonest presentation in ER. The onset of diplopia can be acute onset or gradual onset. We will stress on the acute onset diplopia, and we will mention some points related to the gradual onset diplopia just to help us in the differential diagnosis. There is another clinical tip, what is called polyopia. Polyopia is multiple images of the same object. Can be monocular or binocular. Monocular, if you close other eye, it will persist, and binocular, if you close one eye, it will be abolished. Polyopia is usually called cerebral diplopia, and this is related mainly to stroke, vascular spasm, tumor, multiple sclerosis, or some other occipital or temporal lobe abnormalities. Okay, what about our red flags? When to be panic or when to pay attention to diplopia? In ER, if some patient came to you and said, I am starting to have double vision since 1 day or 2 days, something like that. What is the red flag in each situation? The red flags are, first, the acute onset. The gradual diplopia is not that serious, and it will not kill the patient immediately. But the acute onset means it is very rapid progression, and the patient may be in danger if it is this condition left untreated. Also, the signs of instability. Instability, what kind of instability can be associated with diplopia? If you have some neurological instability like confusion, like loss of consciousness, like coma, this is from the neurological side. From the cardiovascular side, the patient with tachycardia, bradycardia, or hypertension or hypotension, the patient may have some problems with the breathing, shortness of breathing, respiratory failure, or something like that. Or the patient may show some signs of paralysis of respiratory muscles or any other muscle. This is signs of instability associated with diplopia. Some neurological deficit, as we mentioned, some anesthesia, some paresthesia, some paralysis, or some areflexia, some hyperreflexia, something like that. This is a neurological deficit can be associated with diplopia. Also, if the diplopia is a result of trauma, if this patient is involved in something like RTE or assault or direct trauma or fall from height or something like that, and immediately after the trauma, he starts to have diplopia. It is also a warning sign, should be considered as a red flag. Also, signs of infection, if the patient is having high CRP, high temperature, tachycardia, or tachypnea, and the patient is flushed or a toxic lock, this patient should be considered, if he has diplopia, to have serious infection like meningitis or encephalitis. Okay, the etiology of the diplopia is very, very wide. For the monocular diplopia, it is only restricted to inside the globe, as we said before. But the binocular diplopia is having a wide range of differential diagnosis or causes. Okay, we can differentiate the etiology into location or organ etiology, like it is intraocular, conjunctiva, cornea, lens, or retina; orbital lesion, the muscles, swelling in the orbit, fracture in the orbit, or trauma to the orbit; cranial nerve problem, like cranial nerve neuropathy, compression on the cranial nerve, inflammation, neuritis of the cranial nerves; brainstem lesion, like tumor, swelling, lower motor neuron lesion, bleeding, ischemia; or cerebrovascular lesion, like hemorrhage, thrombosis, migraine, arthritis, or ischemia. This is related to the location. It can be differentiated also related to the pathology or the pathological process. Can be neuromuscular pathology, like myasthenia gravis and Guillain-Barré syndrome; autoimmune, like Graves' disease and multiple sclerosis; infection, like meningitis and abscess; intoxication, like vernix encephalopathy, botulism, and scorpion sting; inflammation, like myositis and neuritis; and hysterical, like the conversion disorder. Okay, the history, you should be careful in taking the history of this patient with diplopia. We will start with the time of onset. If it is acute onset, sudden onset, or it is gradual, it is progressive, or it is fluctuating. Sudden onset suggests ischemia or cerebrovascular trauma or cerebrovascular issue. Fluctuation of symptoms suggests neuromuscular disease, and progressive symptoms suggest a compressive lesion. Also, the direction of the diplopia is important in the history. We should ask the patient about it is vertical, horizontal, or diagonal, or what's called torsional diplopia. And also, if the patient is having pain associated with the diplopia. If there is pain, it can be traumatic. And if there is pain without history of trauma, it is suggestive to have some infection. You should also ask about the presence of associated symptoms like neurological symptoms, vertigo, dizziness, dysphagia, ataxia, aphasia, or any other abnormality. Also, for past medical history, especially for hypertension and diabetes, and any vascular disease, and family history, especially for multiple sclerosis and autoimmune diseases. Okay, the physical examination, we have two types of physical examination, the eye examination and the general examination. For sure, we have the eye examination in details. We'll discuss it in details. But apart from the eye examination, we should have complete neurological examination in all cases of binocular diplopia. Especially pay attention of the facial asymmetry, ptosis, cranial nerve abnormality, limb weakness, or sensory deficit. The physical examination of the eye. Yes, first, this is clinical tip. Binocular diplopia due to cranial nerve pathology on one side of the body associated with neurological deficit on the contralateral side of the body raise the suspicion of brainstem pathology. Okay, as the decustation of the motor and the sensory nerves done in the medulla oblongata and the nuclei of the cranial nerves associated with the ophthalmoplegia or movement of the globe are higher than this area. So the affection of the cranial nerves will be on one side, and the affection of the other side of the body will be on the other side, contralateral side. So it is a suspicion of brainstem pathology. The physical examination of the eye should be external eye examination, inspection of the eye and the adjacent structures, visual acuity and visual field examination with pupillary exam, extraocular muscle examination, fundoscopic examination, slit lamp examination, and intraocular um, pressure measurement. Okay, the external eye examination, you should check the orbit, the bare orbit structure, conjunctiva, the positioning, proptosis, ptosis, lid lag, evidence of trauma, and if you have some um, uh, sign of infection like swelling, lid swelling, or periorbital swelling, or something like that. Okay, another clinical tip. After trauma, the patient may develop, immediately after trauma, the patient may develop diplopia related to the entrapment of extraocular muscle, especially the inferior rectus muscle. So after trauma, the fracture of the orbit may entrap one of the extraocular muscles and cause diplopia, and especially the inferior rectus muscle, or can cause some retrobulbar hematoma and cause diplopia due to a pressure on the globe and deviation of the axis. The pupillary exam, the patient will be checked for pupillary light exam, pupillary reflexes, and the asymmetry of both pupils. Also, we have a tip here. If you have patient with cranial nerve number 3, oculomotor nerve palsy, with pupillary dilatation, it raises the suspicion to have aneurysm at the junction of posterior communicating artery and the internal carotid artery. Usually, the pupil in isolated cranial nerve, the third cranial nerve palsy, is spared. The pupil is normal, not dilated and not constricted. If you have isolated cranial third cranial nerve palsy with dilatation of the pupil, it seems to have aneurysm in the uh, um, junction between the posterior communicating artery and the internal carotid artery. Okay, the same issue. If you have diplopia with asymmetric pupils, both eyes are not the same, you should go to MRI or MRA or CT angio or MR angio to be performed immediately to check for aneurysm or space occupying lesion in the um, apex of the orbit. Extraocular muscle exam, you should examine the extraocular muscles through testing the movement of the eye in all directions. We have 6 directions, as you know. And what is called H pattern, examination of the extraocular muscles in the H pattern. Up, down, to the right, to the left, and diagonally in both sides. Here we can see the range of movements. Here is the medial rectus in both eyes. Lateral rectus in both eyes are here. Superior rectus, inferior rectus, superior oblique, inferior oblique, and their innervation, as we said before, all are innervated by the oculomotor nerve, the third cranial nerve, except for superior oblique, innervated by abducent nerve, trochlear nerve, I'm sorry, and the lateral rectus innervated by the abducent nerve, or what's called SO4-LR6. And here, this diagram showed the abnormality related to the extraocular muscle lesion. In the first one, it is normal. Both eyes are normal. In the second one, there is oculomotor nerve or third nerve palsy with deviation of the eye downward and outward with sometimes pupillary dilatation and ptosis. In the trochlear nerve, there is extrusion while the patient is forwarding his vision downward, and in the lateral rectus or the abducens nerve number 6, there is failure of making lateral gaze or lateral direction, so the diplopia will be augmented in this direction. The fundoscopic exam will see the posterior chamber, the retina, the vitreous, and the macula and optic disc, optic nerve, and will find any abnormality in these structures. Slit lamp examination will see the anterior chamber with the conjunctiva, cornea, iris, and lens. And sometimes the lens dislocation or lens subluxation may be acute in onset and cause sudden onset or acute onset diplopia, and for sure it is monocular diplopia. Okay, what kind of investigation we need to do? As a basic, if you have patient with monocular diplopia, there is no investigation should be done. Monocular diplopia should be referred to the ophthalmologist immediately or as soon as possible. If the patient has some issue with the eye and the diplopia is not improved by closing one of the both eyes. If the patient is having binocular diplopia, it is related to the associated symptoms. Here, we will do the routine blood investigation, but especially we will request for CRB for acute infection or inflammation, the ESR for giant cell or temporal arteritis, thyroid profile for Graves' disease, ICE test for myasthenia gravis, and we will discuss it later, CT brain to check stroke, space occupying lesion, trauma, or thrombosis, and the last one, MRI, to check the aneurysm, vasculitis, and demyelination. It is not all required for sure for every diplopia or every binocular diplopia, but it is related to the associated symptoms. If you have any criteria of any special disease, you should do the special test for them. Okay, how to manage? The monocular diplopia, for sure, as we said many times, it is not an emergency. It is not considered as emergency, and it is not threatening the eye or the life. The usual, if you are sure this diplopia is monocular diplopia, you should refer this patient to the ophthalmologist to check if he has some refractive issue or some intraocular disease or pathology. For binocular diplopia, for sure, is related to the underlying cause. What is the cause, and the management will be directed to the cause, whatever the cause. The disposition. Okay, it is related to the cause of diplopia. You should admit the patient if you have suspicion or a confirmation of CVA, cerebrovascular accident, Guillain-Barré syndrome, or any subtype, botulism, intracranial hemorrhage, meningitis, intracranial mass with edema or midline shift, aneurysm causing compression, or multiple cranial nerve involvement. Otherwise, if you have isolated cranial nerve 3 and 4 palsy, the patient can be discharged and given the near appointment with the ophthalmologist unless there is evidence of microvascular ischemia or intracranial issue. Okay, now we are done with the overview or with the scheme of the topic today, but we have some points related to some significant pathology we can consider in diplopia. We have what's called structural or B2 or B2-pathy, or what's called orbital apex syndrome. There is some pathology inside the orbit causing diplopia in some cases. Like if you have myositis, problem in the extraocular muscles, inflammation or pathology, any trauma, infection or abscess, pushing or swelling, pushing the globe, any craniofacial mass, or any pathology restricting the movement of the eye. This is what's called structural or B2 path. In myasthenia gravis is systemic disease as we know. It is autoimmune disease related to the, it's not autoimmune, it is neuromuscular junction problem related to the acetylcholine. And it is the diplopia is part of the generalized weakness in the body. You may find some what's called proximal weakness, including the eyelid and also the extraocular muscles. The signs or symptoms of myasthenia gravis showed to be gradual, fluctuating during the day, increasing by effort and decreasing by rest. And the myasthenia gravis, if you suspect myasthenia gravis, is not fatal and is not emergency, but the patient should be referred to the proper specialty unless the patient showed some life-threatening condition like dysphagia related to the problem in the muscles of deglutition, or dyspnea related to weakness in the respiratory muscles. We have a nice tip here. It is called the ICE test. If you have diplopia related to myasthenia gravis and the patient starts to tell you there is fluctuation in the symptoms during the day, and sometimes it is okay, sometimes it's not okay. If I have some rest, the diplopia will disappear. So you can apply ice test. Ice test to bring some ice, apply the ice to the eye for 5 minutes, and then check the diplopia. You will find the diplopia disappear, as the ice will cause refresh of the acetylcholine receptor and will decrease the weakness in the extraocular muscles and the eyelid. The vernix encephalopathy, it is related to the chronic ethanol use, or sometimes related to bariatric surgeries. For vernix encephalopathy, if you have the good history and good examination, you can start the treatment with IV thiamine infusion. The joint cell arteritis should be considered if you have some diplopia in patients more than 60 years of age. They account for 2.7% of isolated sixth nerve palsy. If you suspect giant cell arteritis or temporal arteritis, you should check the ESR, and it is positive if more than 50, and the patient should be referred to ophthalmology to get temporal artery biopsy to confirm the diagnosis. The botulism poisoning, it is related to foodborne poisoning with botulism. It causes dysarthria, double vision, and dysphagia. And the patient may have diplopia associated with some serious weakness in the vital muscles, and like the respiratory muscle, and the patient may show some dyspnea and need intubation at last. Those patients with botulism, if confirmed, should be admitted maybe sometimes in the ICU. The multiple sclerosis, the typical presentation is a young lady, 18 to 25 years of age, with diplopia and some weakness and nystagmus in the eye. Should be suspected in those age group, and if suspected, we should do MRI to check the demyelination process, and if found, it is confirmatory for multiple sclerosis. Isolated oculomotor nerve palsy, if only oculomotor, as we said before, the patient will have downward and outward gaze in the affected eye, with sometimes normal pupil or sometimes dilated pupil with cerebral or brainstem pathology. And the patient may have ptosis, and if the patient have ptosis, the diplopia will disappear as one eye is covered. So in cases the eye is completely closed, like in trauma or like in infection or swelling or ptosis, the patient will not complain of double vision or diplopia on presentation, especially in ptosis. Okay, we'll jump this one. It is very complicated. Yes, ophthalmoplegic migraine is one type of the migraine with ophthalmoplegia and diplopia at the time of the attack, and it is typically young male with repeated attacks with complete recovery after that, associated with ipsilateral headache. Miller-Fisher syndrome is one subtype of Guillain-Barré syndrome associated with Campylobacter infection, especially with diarrhea and ophthalmoplegia with ataxia and areflexia. The weakness is descending, and it is similarly like the botulism. It is also very fatal if starts to affect the respiratory muscles. Cavernous sinus thrombosis is usually found in middle-aged female, presented with headache, ocular pain, proptosis, and oculomotor palsy. Oculomotor means all cranial nerves related to the eye movement. Plus, you will find palsy in the oculomotor, number 3, trochlear, number 4, and the abducens, number 6. And you will find paresthesia of the face, as the ophthalmic and maxillary division of the fifth nerve, the trigeminal, will be affected also. Last slide is the hysterical diplopia. If you examine the patient, as we said, diplopia is subjective complaint and cannot be confirmed by any examination or any test. If the patient claim he has diplopia, you cannot tell him you are not right or you are a malingering. If the patient is having double vision, you cannot confirm, you cannot deny. So if you start to do all necessary investigation, all necessary tests, all necessary examination, and you all these examinations are fine, normal, there is no finding, at that time you should think about the hysterical or conversion diplopia. The conversion diplopia you can differentiate from other types of diplopia with two criteria. The first one is the obvious indifference, and the second one is the secondary gain. The obvious indifference, the patient will start to complain of diplopia, but the patient is not taking it seriously. The patient is having some indifference, and it is not important to him, and he will not complain every now and then, and he will not stress himself as he has diplopia. The secondary issue is the secondary gain. The patient should have some, on analysis, the patient should have some gain to have diplopia at that time. Gain means escape from stressful condition or gaining some sympathy from others if he has some this kind of pathology. That's it for today. I try to make it simple as much as I can. It is very big topic and it's very complicated if we go through all the details. Now we can give the floor to anybody who wants to ask any question. Otherwise, thank you so much.